Welcome to another lecture by MedicoMedics, Helicobacter pylori. We will begin with a general introduction of H. pylori. We will discuss normal physiology, pathophysiology, and then compare the two. We will follow with symptoms, a case example, discuss diagnoses, differential diagnoses, treatment, and end with a summary. And for our medical students, we recommend looking at our high-yield review. Now, before we dive into the details and the pathophysiology of H. pylori, let us begin with a general introduction. So, H. pylori is a gram-negative, spiral-shaped bacterium that colonizes the gastric mucosa, leading to potentially chronic gastritis, peptic ulcers, and is associated with gastric malignancies. Key features include that it is the most common chronic bacterial infection globally, causes asymptomatic infection in the majority, but leads to disease in susceptible individuals. It is mainly transmitted via the fecal-oral route or oral routes, often acquired in childhood. It affects approximately 50% of the global population, with higher prevalence in low-income regions. It is also strongly associated with poor sanitation and overcrowding. So, as we mentioned, it is caused by H. pylori, which produces urease, enabling it to survive in its acidic environments. Risk factors include smoking, the use of NSAIDs or non-steroid anti-inflammatory drug use, and genetic predisposition. We will dive deeper in our pathophysiology section on this part. Now, major clinical importance. So, it is the major cause of peptic ulcer disease. It is further strongly linked to gastric cancer and mucosa-associated lymphoid tissue lymphoma or MALT lymphoma. Eradication reduces the risk of ulcer recurrence and gastric malignancies. Now, before we dive deeper into the pathophysiology of H. pylori, let us briefly review the normal physiology of the stomach. Now, under normal conditions, the stomach is a highly acidic environment, and this is essential for both digestion and defense. Now, this acidity that is normally found in the stomach is mainly due to hydrochloric acid, or HCl. And this is secreted by our parietal cells. This helps to break down food and kill harmful microbes. However, because this acid is so strong, the stomach must protect itself. And this is done by the mucosal barrier, which includes a layer of mucus and bicarbonate that shields the stomach lining from being damaged by its own acid. So the balance, the balance of acid production is carefully regulated by gastric hormones. For example, we have gastrin and somatostatin. So gastrin stimulates the parietal cells to produce more acid when needed. So gastrin stimulates acid production, meaning it stimulates the parietal cells. And as we just mentioned, the parietal cells secrete the hydrochloric acid. Now, somatostatin inhibits acid secretion. So it acts like a brake in a car, right? So somatostatin inhibits acid secretion to prevent overproduction. And it is this very fine-tuned interplay between gastrin and somatostatin that keeps digestion efficient while preventing self-injury. Now let us turn our attention to the actual pathophysiology of H. pylori. We can break it down into several steps, beginning with colonization. Then we have urease production, mucosal damage, inflammation, and different disease outcomes. So let's walk through the pathophysiology of H. pylori using these slides here. So first, we see that H. pylori here is a spiral-shaped bacterium that can survive in the stomach's acidic environment thanks to its urease enzyme. This urease enzyme helps neutralize acid locally. So this allows it to colonize the mucosal layer of the stomach lining. By converting urea to ammonia, it is neutralizing stomach acid, so it creates a hospitable environment for it to thrive. Once it's settled, it begins producing enzymes like mucinase, and the acid and pepsin further contribute to mucus layer damage, exposing the epithelial cells beneath. So once it's entered, it converts urea to ammonia, makes the environment more hospitable so it can continue to survive. It then targets our mucosa, and cytotoxins and different inflammatory mediators all begin to damage the epithelial cells and continue to disrupt the mucosal barrier. So H. pylori then releases these cytotoxins, right? Such as VacA, for example. And these directly damage the epithelial cells, leading to cell death. At the same time, this cellular injury, right? Because there will be a response to it. It will trigger an immune response, bringing in inflammatory cells like neutrophils. However, H. pylori persists despite this immune activity, and this leads to a chronic inflammation. Over time, right? Over time, this combination of direct bacterial damage plus the immune-mediated injury that happens leads to further mucosal damage. And this predisposes the patient, for example, for having or developing ulcers or gastritis, and in some cases, even gastric cancer or malt lymphoma. And despite a quite simple pathophysiology, one thinks there are several layers of medicine and medical subjects that underlie all of these different steps. So first of all, the ability of a pathogen to adapt itself to an environment, right? The stomach is acidic. It's supposed to destroy these bacteria or these pathogens. However, for whatever reason, this specific one has the ability to adapt. Now we need to be interested in how it does that. We realize that, oh, it has an enzyme that converts urea to ammonia. This will neutralize our stomach acid. Now we understand that the acidity, the protective environment of our stomach has become compromised. And this will make the H. pylori continue to thrive. But it's not finished, because now it will proceed to continue damaging our epithelial cells or our mucosal barrier. And that's half the story. The other half is our natural response to it, which is our immune system reacting to it. And as always, an immune response is, in theory, a good thing. But the overactivity of the immune system very often leads to negative outcomes, because the inflammatory response and the mediators that get activated continue to disrupt and damage this area, for example. And once that kicks in, you now have a chronic process in place. Over time, this chronic infection or problem will then develop potentially very severe outcomes. Now let's look at symptomatology. So in about 80% of cases, we will have asymptomatic infections. But if presented with symptomatic infections, we can identify, for example, gastritis. They will typically present with epigastric pain or discomfort, nausea, bloating, and belching. If we're dealing with a peptic ulcer disease, the patient might present with burning epigastric pain, often relieved by eating or antacids. We can also see nausea, vomiting blood, or black stools. Now you may wonder, how come the burning epigastric pain is relieved or often relieved by eating? The reason is because food buffers the stomach acid temporarily. This reduces the acidity that irritates the ulcerated gastric or duodenal lining, providing a short-term relief. And this is especially common in duodenal ulcers. Now, you may again think or wonder, but how does adding more acid help relieve it? Well, what's important here is that when we say buffering the acidity, right? It buffers the stomach acid, right? After we eat. When we say buffering the acidity, we don't mean adding more acid. We actually mean reducing the acid's effect by temporarily neutralizing or diluting it. So if you want to think about it step by step, before you eat, your stomach is empty, but still it produces acid, right? Now in this unbuffered state, the acid can irritate the exposed ulcer, causing that burning pain. However, when you are eating, the food acts like a temporary buffer. It absorbs and dilutes the stomach acid. It raises the pH, so it makes it less acidic for a short time. And this is what soothes the ulcerated area, reducing the irritation and pain. A bit later, food stimulates more acid production via, if you remember, gastrin, as we mentioned in our normal physiology of the stomach. So a bit later, food will stimulate via gastrin more acid production, but that increase happens after that temporary relief. And this may then cause rebound pain. So eating doesn't add acid right away. It first calms the stomach environment. That's why duodenal ulcer pain is classically relieved by eating. Now, we also, of course, need to mention complications like gastric cancer, which will then present probably with weight loss, persistent pain, and anorexia. If we have a mold lymphoma, which is quite rare, however, associated with prolonged infection. And these are, of course, causes for immediate response to with proper treatment. So let us briefly connect the pathophysiology with its related symptoms. So we mentioned that H. pylori converts urea to ammonia, so urease activity. This neutralizes gastric acid, enabling H. pylori to survive. This could be detected by urease breath test or rapid urease test during endoscopy. What about cytotoxin production? So VacA, which actually stands for vacuolating cytotoxin A and is a major virulence factor produced by Helicobacter pylori. And the name comes from its ability to induce a vacuole meaning a fluid-filled cavity formation in epithelial cells, and this leads to cellular damage. So VacA and other toxins will then disrupt epithelial cells and promote mucosal injury. So if we have that cytotoxin production, we should see mucosal damage leading to the formation of ulcer. And we should then see the physical symptoms like nausea or epigastric pain, etc. What about chronic inflammation? So immune response, like we mentioned in our pathophysiology, the immune response causes persistent gastritis and mucosal irritation. Symptoms patients will present with is typically dyspepsia, bloating, or intermittent upper abdominal discomfort, for example. And we can identify chronic active gastritis with gastric biopsy. And then gastric epithelial damage. So essentially, long-term inflammation leads to atrophy, leads to metaplasia and dysplasia. So it is often quite silent, but late signs will include, for example, anemia, weight loss, for example. So what would be a typical case example? Well, we have a 45-year-old man presenting with burning epigastric pain that worsens at night and improves after meals. So eating is relieving temporarily his pain, but at night his pain is worsened. He also reports intermittent nausea and bloating. Very common for duodenal ulcers here. So what do we find then? We do a physical exam and we observe a mild epigastric tenderness. We do our diagnostic tests and we see a positive urea breath test. Endoscopy reveals a duodenal ulcer. How do we then manage it? Well, we initiate triple therapy with omeprazole, clarithromycin, and amoxicillin for 14 days. And we follow up with a urea breath test to confirm eradication. We will look into diagnosis in coming slides and also review treatment. But this could be a typical case example. But then how do we go about diagnosing it? So we have the non-invasive test, like the urea breath test. It detects urease activity by measuring labeled carbon dioxide in the breath. And you should be able now to connect this specific test to the pathophysiology of H. pylori. Remember the activity of an enzyme that converted urea to ammonia. Why? To make the environment in our stomach less acidic, more hospitable for H. pylori to thrive. So that's the reasoning behind this test. We can do stool antigen test, which identifies H. pylori antigens in stool samples. And of course, serology, detecting antibodies. However, it's not super useful post-treatment. Then we have the invasive tests, like endoscopy with biopsy. So histology confirms the presence of H. pylori. Again, rapid urease test. Detects urease in biopsy samples. We can do a culture for antibiotic sensitivity testing in resistant cases. Now let's look at some differential diagnoses of H. pylori. So what if it's a non-H. pylori peptic ulcer? Well, key differentiating features would be no evidence of H. pylori, and this is more likely associated with NSAIDs use or stress ulcers. What about gastroesophageal reflux disease or GERD? Well, we should observe heartburn and regurgitation, no direct link to H. pylori. Functional dyspepsia. We should observe chronic epigastric discomfort without identifiable cause on imaging or biopsy. Zollinger-Ellison syndrome. Recurrent ulcers with elevated serum gastrin caused by gastrin-secreting tumor, meaning gastrinoma. Again, try and connect it to the normal physiology we talked about. What was the role of gastrin? We had gastrin and somatostatin. One of them increased the activity of our parietal cells to increase the hydrochloric acid level. So if we have a gastrinoma, we will have a gastrin-secreting tumor. As gastrin is oversecreted, we will have an overstimulation of our parietal cells, which will lead to elevated levels of hydrochloric acid. And this does what? It elevates the acidity in our stomach. But this is a different pathophysiology compared to H. pylori. So when we have diagnosed H. pylori, let us now move on to treatment and management. And our first-line therapy includes a triple therapy for 14 days. It consists of using a proton pump inhibitor, like omeprazole, 20 milligrams twice daily, clarithromycin, 500 milligrams twice daily, and amoxicillin, 1 gram twice daily. Or if the patient is penicillin allergic, we give instead metronidazole, 500 milligrams twice daily. Alternative therapy includes bismuth quadruple therapy, so proton pump inhibitors, bismuth, tetracycline, plus metronidazole. However, we have to be aware of antibiotic resistance, so increasing resistance to clarithromycin necessitates susceptibility testing in refractory cases. And we should, of course, always follow up. So to confirm eradication, we do a urea breath test or stool antigen test 4 to 6 weeks after therapy. How can we prevent H. pylori? Well, improved hygiene always helps. So access to clean drinking water and proper sanitation. Public health measures, so education on hand washing and safe food preparation. Screening and treatment, so early detection in high-risk populations to prevent complications. What are some complications then of H. pylori? Well, we mentioned peptic ulcer disease, so gastric and duodenal ulcers with a risk of bleeding, risk of perforation, and gastric outlet obstruction. Further, gastric cancer, so chronic infection increases the risk of adenocarcinoma. Malt lymphoma can often regress with H. pylori eradication. And finally, chronic gastritis, so persistent inflammation, may progress to atrophy and intestinal metaplasia. So let's just select one of these. We can take peptic ulcer disease and just give it a bit more context and relating it to the rest of the lecture. So peptic ulcer disease, right? We're talking about gastric and duodenal ulcers with risks of bleeding, perforation, and gastric outlet obstruction. So if we connect it to the pathophysiology we've talked about, H. pylori colonizes the gastric mucosa, right? It produces urease. The urease converts urea into ammonia. You all remember this. Now, this ammonia will help neutralize the stomach acid locally and also damages or leads to damaging the epithelial lining. This all leads to inflammation and disruption of mucosal defenses, allowing acid to erode the mucosa and form ulcers. For example, a patient presents with epigastric pain and it improves with eating, right? Which was a classic sign for duodenal ulcer. We do an endoscopy and it reveals an ulcer in the duodenal bulb. And then we do a biopsy which confirms that it's H. pylori. Now, if there is continued erosion, it can lead to bleeding. For example, melena, so bloody stools, or vomiting blood. Continued erosion can also lead to perforation, leading then to peritonitis, or scarring that can cause gastric outlet obstruction. So whether it's bleeding, whether it's perforation, whether it's obstruction, these are all very, very architectural changes that occur. So in summary then, H. pylori, a chronic bacterial infection by H. pylori. It is acquired via the fecal-oral or oral-oral transmission. Symptoms, often asymptomatic or presents with dyspepsia, epigastric pain, and ulcer complications. We diagnose it with a urea breath test or stool antigen test, and endoscopy with a biopsy. Treatment includes typically a triple therapy or a quadruple therapy for eradication. Some complications we mentioned: peptic ulcer disease, gastric cancer, and chronic gastritis. And of course, don't forget the follow-up to make sure that it has been eradicated. And finally, we arrive at our high-yield review for our medical students. Feel free to pause the video and repeat. And that's the end of this lecture. Thank you for listening. If you liked our video, please like and subscribe for more videos.